The TAVR procedure is the replacement of the aortic valve, which is the valve that lets the blood out of the heart. An ideal candidate for this procedure is an elderly person who is often very frail and may have multiple other medical conditions, who is either a very high risk or unable to sustain the storm of conventional open heart surgery. These elderly patients usually have developed a serious obstruction of blood flow out of the heart due to the accumulation of calcium on the aortic valve. So the first thing we do is to confirm that this patient or these patients have severe aortic stenosis by doing a high quality echocardiogram study. Next, we confirm that this patient has developed a restriction of their activity because of inadequate blood flow coming out of the heart to meet the requirements of the body. And these patients usually will be unable to do their normal household chores. They get very short of breath. They can go into acute heart failure. They can get chest pains. They get lightheaded, and they can pass out. Once these patients with severe aortic stenosis develop symptoms, not only is their quality of life markedly diminished, the longevity of these patients is not there. It's a collaboration of multiple physician specialties and the hospital specialties. We have 2 cardiac surgeons, we have at least 2 interventional cardiologists. There is an anesthesiologist who may work also as an echocardiographer. I will have an assistant with me who's a certified nurse anesthetist. We have the open heart scrub team there, the perfusion team is there, the cardiac cath lab team is there, and in all, there's 30 to 40 people involved in this procedure. I play a dual role. I am the anesthesiologist responsible for making sure that the patient is asleep and comfortable, and I also do the transesophageal echocardiogram. Once the patient is asleep, we put a gastroscope like you have an endoscopy, except instead of a camera at the end of this scope, there is an ultrasound probe through which we can evaluate the heart continuously. Once the patient is asleep, the first thing we do is verify the size of the aortic root. I measure out the size of the annulus in 2D and 3-dimension echocardiography, and we discuss with the team and decide on the size of the valve we're going to use. After this, during the procedure, once the valve is deployed, echocardiography plays the most critical role because we have to immediately evaluate if the valve was deployed in the right place, if it slipped a little bit higher or lower, and if there's any leaks around it, and if we need to do anything immediately, echocardiography guides that. So these are the critical roles that I play in this procedure. There is very little pain. There's 2 approaches we use. If the size of the vessels from the groin are adequate, we go through the groin, and this is a minimal procedure and has pretty much no pain. But if the size of the blood vessels is not adequate to deliver the valve through the groin, or the aorta is diseased, then we use a transapical approach, which involves a small incision in the chest. Now, these people have a little bit more pain, but it is nothing compared to the pain that they would have if they had open heart surgery. We also do a block in these people to minimize the pain, and these people also look excellent the following day. This is the best part of this procedure. It is heartwarming to see these patients who are so critically ill very frequently being extubated in the operating room, and next morning we go to see them. They are sitting by the bedside, having their breakfast, reading the newspaper, as if nothing happened the day before, and they have had their aortic valve replaced by this, transcatheter procedure. Not just that, to see them resume their day-to-day chores that they were not able to do before, start playing golf, going back to tennis, the quality of life improves tremendously when this procedure is performed successfully.